So, hello everyone. And also from my side, Michael, Anna, thanks a lot for inviting me over and having the opportunity to share some of our clinical experience and data with you today. So my talk shall be on combined immune deficiency with a clinical focus on diagnostics and management in this condition. I actually not focusing this talk on SCID, but I think it's difficult to start a talk on combined immune deficiency without mentioning SCID, as this is really the disease that has determined our focus on this disease. Many of you are familiar with severe combined immune deficiency, so we can go through this rather quickly. So SCID is a disease that has an onset in infancy. Some patients present with failure to thrive prior to the onset of infections. They have a problem in T-cell development and function, so you usually do not see a thymus, and patients lack or have very little T-cells. There's variants where B cells are not affected and are then called B plus SCID, or B cells are lacking and then called B minus SCID. Patients are prone to infection, which is the leading clinical presentation, in particular opportunistic infection like pneumocystis, or another big killer is CMV, transmitted often through the mother. There's a variant of the disease called Omenn syndrome. These patients do have T cells, which however do not help because they're autoreactive and cause a lot of harm. And whether this is Omenn or classical SCID, there's little doubt in the community that the treatment of choice is exchange of the immune system, and this is usually done by bone marrow transplantation. So, but looking at combined immunodeficiencies in total, I think that SCID really is rather the tip of the iceberg, and that there is a large group of non-SCID disorders which have been below the surface for many years, but that are now really showing up to our clinics. And there's a lot of management problems that evolve from these patients because we know very little about their histories and optimal treatments and treatment time points. The genetic basis for these non-SCID T-cell disorders is very broad. There's many diseases that contribute to this combined immune deficiency phenotype. There's on one side are those patients that do have mutation in SCID-causing genes, but are, for example, hypomorphic. That has been long and well described for a patient with RAP mutation, where residual protein function allows for a certain function of the protein and residual T-cell immunity, yet leaving the patient with enough clinical problems because T-cell immunity is not complete. Then there's a large group that is, and this list I'm presenting it's really incomplete, that is evolving over the past years, and this is a group of patients that we like to call bona fide CIDs. DOC8 is a maybe more prominent representative of this group, and this is a group where null mutation in one gene do not lead to a full clinical picture of a SCID, but severe T-cell impairment leading to clinical problems in these patients, and I will come to the clinical pictures in a minute. There's a group of radiosensitive disorders, some patients with ataxia, ligase 4 Senunos, for example, a group of syndromic PIDs, cartilage hair, or some patients with catch-22. And then there is a large group of new defects that do not always present with a combined immune deficiency, but where some of these patients have impaired T-cell immunity and then also present with combined immune deficiencies, for example, gain-of-function mutation in STAT1, also a dominant mutation activating in PI3 kinase delta, CTLA4, or LRBA, which is a recessive condition. So looking at this large, very heterogeneous group from a treatment perspective, there are a few things that are clear and other things that are not clear. So it is well established that for SCID, basically stem cell transplantation is today's standard treatment of choice. On the other side of the spectrum, there's adult, late onset combined immune deficiency, or even further down the road, very mild CVID, there's also little doubt that most of these patients will do fine under supportive treatment, and that there are only very, very few patients who require stem cell transplantation. However, most of these patients that I would like to focus you on today is a relatively large pediatric cohort that is in between these extremes, and about these patients we know very little in terms of treatment decisions. We often do not know the true natural history in these conditions. All of these are very rare, and we usually have just a few case reports reported in literature. We do not know much about the optimal time point for transplant, and it would be very nice if we could have clinical or laboratory predictors that could help us with this decision. And we've initiated a study that has a focus on these problems, and I will come to this later at the end of my talk. To provide you a little bit with a better feeling for these diseases that I've just outlined a bit, I prepared 2 case reports from patients that we have seen in our clinics over the past years. So case number 1 is a child that we got to know at the age of 5. So this is a history, how he presented in our outpatient clinic. He's the first son of healthy, unrelated German parents. He suffered from recurrent bronchitis. He had bronchiectasis. He had, with 14 months, granulomatous skin lesions. Parents showed us these pictures. This was actually a self-limiting disease. The patient had no symptoms when we saw him. With 21 months, he had a severe systemic salmonella infection from which he recovered fine. And the reason for referral was persisting lymphopenia around 1,000. He had an otherwise unremarkable clinical history. He was fit, playing football. What was not so unremarkable was his family history. This is a patient, and you see that his mother had a brother, so a maternal uncle of this child, who deceased in infancy after a history of serious infections. So we looked at the immunological phenotype of this child and found that his lymphopenia was due to reduced CD4 and CD8 cells. He had an expansion of gamma delta T cells, shown here by 50%. He had reduced naive T cells, suggesting an impaired thymic output. However, T cell proliferation was perfectly normal. His T cell receptor repertoire was mildly skewed, generally it was broad. B cells were normal, but he was not able to mount antigen-specific responses, negative vaccine responses. IgG was moderately low. NK cells were reduced, so a T low, B plus, NK minus phenotype if you think in a classic SCID setting in this 5-year-old child. Now, still thinking classic SCID with a possible X-linked inheritance, we thought, well, maybe this is a late onset X-SCID patient, so we sent off DNA to Klaus Schwarz in Ulm to sequence the common gamma chain, and indeed Klaus found a new mutation in the common gamma chain, which lies in the pocket where the common gamma chain interacts with IL-2, but Klaus did not only find the mutation, but 30% of the signal in his sequencing sequence was carried due to wild-type sequence. So we wondered what might be the reason for this. We thought maybe there's still maternal cells around, what we excluded by STR analysis, so we thought maybe this child might have a genetic reversion, a somatic reversion back to normal. So what we did, we sorted several cell types, and indeed what we found was that there was mutation present in various cell types, buccal-mucosa, granulocytes, B cells and NK cells, but all of the patient T cells, and that was true if you looked in total or separately for alpha, beta, and gamma delta, all T cells had wild-type sequence. So genetically, these T cells were normal. So what we believe has happened in this child was that at some stage, that is not retrospectively determinable, he had a mutation back to normal, a somatic reversion, and this must have most likely taken place at the level of a committed lymphoid progenitor cell, and due to the selective survival advantage, this naturally occurring gene therapy gave rise to descending genetically normal T cells among gamma delta and alpha beta T cells, but because this repertoire is probably not so broad as if you would have a genetically normal stem cell pool, the repertoire is not as diverse. T cell probably function a bit less, and this obviously there still was mutation in the B cells of the patient contributing to the immunoglobulin production problem in this child. So that's one case. The second case I would like to show to you today is another 5-year-old boy. He's also a child of non-consanguineous Caucasian parents. He was referred from Poland. He had infections, recurrent respiratory tract infections since late infancy. He had chronic cough. Was once admitted to ICU because of pneumonia, did not require ventilation. He had a systemic CMV infection at 1.5 years, which cleared after ganciclovir treatment, and he was having recurrent mucocutaneous candidiasis. He had significant immune dysregulation. There was a chronic diarrhea from 2 months onward, and on scope there was follicular hyperplasia identified, and he had chronic hepato and splenomegaly since age 2 and generalized lymphadenopathy. Again, this was a child with moderate lymphopenia. He had thrombocytopenia, difficult to tell whether this was autoimmune and or due to hypersplenism. Also, this child had hypergammaglobulinemia. He was treated since age 3 with subcutaneous immunoglobulin. His IgM was initially normal but increased over time. So here are some clinical impressions from this child. You see very significant splenomegaly. He had on CT an interstitial lung disease with opaque ground glass appearance, bronchiectasis, consolidation of his middle lobe, and you see the follicular hyperplasia from the scope. So we again looked at the immunological profile of this child. He had reduced CD4 cells, not tremendously, but for age significantly reduced. CD8s were normal. B cells were lowish, as well as NK cells, present but reduced. Again, significant reduction of naive T cells. First looked at the age of 5. We don't have previous values. Gamma delta T cells normal. But what we found was that there was evidence for increased senescence among his CD8 cells, with a high positivity for CD57 on his CD8 cells, here and shown in control to a healthy control. Proliferation was normal, shown here by CFSE, and from the B cell side he had low IgG and this hyper IgM phenotype with an IgM of 320 at age 5. Looking again at your CID gene shopping list, what is the diagnosis? To cut this short here, this is a child with activating mutation in PI3 kinase delta. Some of these patients present with hyper IgM, which was a trigger here to investigate in this direction, as well as the increase of senescent CD8 cells. So PI3 kinase delta has been a disease that, or activating mutation in this gene, have been a condition that was more recently described by 2 groups. Initially, the complete consequences of these activating mutations are not fully understood, but this is the current published concept. So it's believed that this augmented, in this case increased PI3 kinase delta signaling results in increased glycolysis, which causes CD8 cells to differentiate into effector cells, which vigorously proliferate, causing those lymphoproliferative problems we see in this patient, possibly contributing also to the lung disease, which is very frequently seen in these patients. T cells develop into a senescent phenotype, and that may contribute to the impaired control of EBV and CMV, and later also those patients are prone to develop lymphomas. So what are my take-home message from these 2 cases to you? Rare genetic events like reversion in this first patient, but more frequently hypomorphic situation as well described in many, many patients with RAP mutations, can attenuate the clinical phenotype of SCID, then resulting in a later onset of the disease. But combined immunodeficiency is not limited to alteration in SCID genes. There are many, many more genes and new defects that are popping up that make patients present in a very similar fashion. Those patients have limited but relevant residual immunity, and this immunity may be strong enough even to cause significant clinical problems with a lot of autoimmunity that we see in these patients. So these patients are there. So how can we recognize them? How can we recognize a patient and distinguish a patient with PI3 kinase delta from, let's say, a patient with autoimmune lymphoproliferative syndrome that has a large spleen and autoimmune cytopenias? Now, how can we identify a patient with combined immune deficiencies from a diagnostic point of view was a focus of a study that Karstene from Stefan's group undertook a couple of years ago and was published in Clinical Immunology in 2011. Karstene looked at 70 patients retrospectively and 10 patients from our center. What were the clinical findings and what was reported from the laboratory observation in these children? This was a study that has a focus on patients with hypomorphic SCID mutations. And to cut this short for you, there's basically no gold standard. There's not one single value that can tell you this child has a combined immune deficiency. It's the combination of markers, and these are 4 items that are particularly important. This is T cell numbers, which are usually reduced, naive T cells reduced, gamma delta T cells, which we frequently see expanded above 10%, and T cell proliferation is reduced. And if your patient has 2 of these 4 criteria changed in a pathological way, then your patient is very likely to have an underlying combined immunodeficiency. So these patients are there. We know now how to identify them, but what do we do with them? How should we treat them, and when should we transplant these patients? Again, I've shown you this slide before, and those emerging questions, what is the natural history, what is the optimal time point to transplant, are there clinical or laboratory predictors to foretell which patients are in particular risk to develop a problem, has been really the burning question that were driving us to initiate a new study 3 years ago. And this study is called the PCID or PCID study, derived from profound combined immune deficiency. It's a study that is Stefan is coordinating and has been set up as an international multi-center study to really collect as many of these rare patients as possible. Currently there are 19 centers participating across Europe and the Middle East, and we recruit patients over a period of 5 years. We intend to recruit 40 patients per year. We have currently achieved 80 patients to be recruited for this study, and we aim at 120 to 200 in total. So we include patients between the age of 1 through 16. The inclusion criteria are now familiar to you, so patients need to have lab evidence for combined immune deficiency. That is 2 out of 4 criteria, either reduced T cell counts with age-specific values, reduced thymic function, impaired T cell proliferation, or an elevation of gamma delta T cells. And in addition to this lab evidence, patients also need to have at least 1 clinical event in their history, so severe infections, immune dysregulation, or occurrence of malignancy. We then see a patient at the initial study visit, perform a baseline clinical assessment, also looking at the retrospective clinical history from birth. We assess laboratory data, quality of life, and document the single center's decision whether this child is transplanted or not. The study does not make any suggestions or recommendation, we just follow up the local center's decision. So naturally, there are two arms, those who are relatively forwarded early to stem cell transplantation and those who are followed conservatively. In both arms, then patients are followed up in yearly intervals and are then again assessed for their clinical data, what has happened to them in the past year, laboratory data, quality of life, and in those non-transplanted patients, again, we ask for a reassessment. Will you transplant this patient? Why or why not? And among those, there may be patients who undergo late transplantation during the course of the study. And in the end, we will again assess for then quality of life, frequency of severe events, and survival. So this is how, in theory, it looked. How it looks in real life, I will show you in a minute. So we recruit patients with very different clinical careers, so to say. There's some patients that had a long-standing history up till inclusion into the study with several clinical events and then are transplanted and followed during the study. We have younger patients which may be not transplanted, patients with very severe clinical course and many events, and patients that are very mild. There are two phases of the study. There's a retrospective analysis, all of what has happened to the patient prior to inclusion, and more importantly, this prospective evaluation. What we have now carried together is data from the first 51 patients who have been in the study for at least 1 year, and we have looked at the retrospective clinical history of those first 50 patients, and this is data I would like to share with you in the last remaining minutes of my talk. So what is in our study? How is the study population put together? This is what we have, the first 51 patients. So there's two large genetic groups, those that can be summarized as atypical SCID, so these are patients with mutation in SCID-causing genes, hypomorphic mutation. Among those, there is a particular occurrence of RAC mutations, and then all other candidates that are associated classically with SCID. So these are usually, again, hypomorphic mutations. And the second group, equally strong, is the group of bona fide CIDs, and this is a mixed bag of various conditions: Nijmegen breakage, SEP70, DOC8, ITK, cartilage hair, TPP2, a recently described defect by Stefan, PI3 kinase delta, caspase 10, and coronine 1A. There's still a large group of patients that has no identified genetic defect yet. Obviously, this is something that will need more thorough workup as the study continues. We recruit across the entire age range between 1 and 16 in all genetic subgroups. So when do those patients become sick? When do they present to their doctors initially? This is summed up in this panel A. So you see that roughly by age 2, 70% of patients had their onset of disease. So also if we say late or delayed onset combined immune deficiency, it is a disease of infancy. It is a disease that presents early and then puts the patient at significant clinical risk. What are the presentation? What takes them to their physician? Why do they present initially? This is summed up here in panel B. I've told you that we see a lot of immune dysregulation, and here you see that it's also true in the study cohort. Half of the patients initially present with an autoimmune problem. So if we look at these more in detail, this starts here from number 6. We have mediated autoimmune disease, skin disease, so that is basically severe eczema, inflammatory bowel disease, lymphoproliferation, autoimmune cytopenia. This is the reasons why children present first to their doctors. Of course, we also see infection as first CID-related illness, but that is not more frequent than immune dysregulation. Among infection, we particularly see invasive bacterial infection, probably reflecting the high incidence of hypergammaglobulinemia in this cohort. Very often these are invasive pneumonias. We also see a severe and acute viral infection. We do not see so much opportunistic infection as in more severe combined immune deficiency. How does this contribution of infection versus autoimmune disease then proceed? This is summarized here in this bit difficult to read graphics. I will try to walk you through. So what you see here on this axis is the percentage of infectious versus autoimmune events in these patients. That means that those patients here, which represent the largest number among those patients, around 50% have an equal balance between autoimmune and infectious related problems. You see that there's very few patients who only have or predominant have infectious problems, but there's a significant number of patients. Each triangle represents an individual patient that exclusively has autoimmune related problems, and this proves to be a true this distribution in those patients who are judged to be rather mildly or severe affected by clinical judgment of their treating physicians. So again, immune dysregulation is a major complication in these patients and may be the only occurring problem in this population. So looking at the severity in these patients from a different point of view, 5 patients of those who have been in the study for 1 year have died, so that's 10% of the cohort. 2 of those were shortly after transplant, and 3 others prior to transplant or were not transplanted. All deaths occurred due to infections, so infections still are the main killer in this cohort. Looking at transplantation, among those patients who were in the study for 1 year, 37% have been transplanting, really showing that this is a condition where transplant indication is an issue. Children are significantly sick, so transplant is considered. Looking at those who were judged to have a severe course of disease, and these were 25, so half of those recruited patients, only 13 were transplanted. And the reason for not transplanting the others were either lack of donor, denial by the family, or actually that the clinical course was judged to be already too severe to make this procedure possible, and 2 patients died in preparation of this procedure. The other half of the patients were judged to have a mild course of disease. Among those, 6 were transplanted, all for prophylactic reason because of an assumed course of the disease, for example, in anticipation of another family member. So this has been some of the data we've now achieved on the retrospective analysis of the first patients. What we are now starting to do is to really compare individual clinical courses to, in the future, hopefully identify clinical courses, patterns, or laboratory markers that may help to identify patients that have a certain risk to develop problems over time. And what is summarized here by each diagram is the individual clinical history of a patient. In total here are shown clinical careers of patients with RAC mutation. So there are several things you can read out of this diagram. First, although all of these patients have RAC mutation, they have a very different clinical career, so the genetic underlying diagnosis does not generally foretell the clinical outcome. What you see also by these stair diagrams is the course of clinical events. So each stair up means something happened to the patient. In black, this is the total events, red infections, blue autoimmune. So this might be onset of pneumonia, another pneumonia. Here the patient had autoimmune cytopenia, onset of colitis, etc. And what this enables us to do is really to follow up patients over time and to match, for example, patients that have a very similar course of disease, to match patients who were transplanted or will be transplanted and not. So this is the idea really of having matched pairs to follow up over time to hopefully try to shed some light on those questions that I rose initially. What is the optimal time point for transplantation? How can we identify patients? So this is still a lot of work that is ahead of us. So in summary, The cohort that we've set up has the targeted disease burden of infection, autoimmune dysregulation, really reflecting a profound clinical condition, a profound combined immune deficiency. The cohort has the expected genetic heterogeneity. We see that half of the genetically identified patients have mutation in SCID genes, the other half in more bona fide CID-related genes. The HSCT rate is high, showing that there is clinical need to perform transplantation in these patients. We therefore think that the cohort structure is appropriate to follow up the idea to achieve the study goal, to look into this cohort more closely to identify predictors for clinical deterioration, for example. But of course, further recruitment and long-term follow-up is required, and we're still looking for dedicated centers who would like to participate in the study. So I'd like to thank a large cohort consortium of dedicated physicians that is contributing to this study, our patients and their families, and you for your attention. Thank you very much.